Bismillah. Now let's continue from where we left last time. We are going to talk about the pectinate line. Okay, so the pectinate line, it is formed where the endoderm in the hindgut meets the ectoderm. So basically, hindgut, it is present. The pectinate line is present inside the rectum, and it is the point where the endoderm and ectoderm are fusing together. So above the pectinate line, we get internal hemorrhoids. Just give me a second. Yep. So above the pectinate line, we will get the internal hemorrhoids and adenocarcinoma. Internal hemorrhoids receive the visceral innervation and therefore not painful. So basically, this pectinate line, this dentations like this thing, this is the area where there is a sharp demarcation between the endoderm and the ectoderm, and there are a lot of other differentiation between above and below the pectinate line in the innervation, in the blood supply, and the lymphatic and stuff like that. We'll see that now. That above the pectinate line, the innervation is the visceral innervation, that is autonomic innervation. The pain fibers, the pain sensations is not present in the above the pectinate line. The arteries that are supplying above the pectinate line are the superior rectal artery, which is a branch of the inferior mesenteric artery, and inferior mesenteric artery, it is the blood supply for the complete hindgut up till the pectinate line. The veins are superior rectal vein, in parallel to the superior rectal artery. So superior rectal vein that drains into the inferior mesenteric vein, that goes to the splenic vein and ultimately to the portal vein. The lymphatics, they drain into the iliac lymph nodes. So the internal iliac lymph node, the lymphatics are very important because they ask you about this, number one, and number two, because the lymphatic drainages are important when we talk about different kinds of carcinomas and stuff like that. So that is why they always insist you, and they always give a very huge focus on the lymphatic drainages. So you must remember them. So the lymphatic drainage above the pectinate line is going to the internal iliac lymph node, and now let's see what are the blood supply and the innervations below the pectinate line. Just give me a second. Yep. So below the pectinate line, as you can see over here, the innervation is somatic innervation. What is meant by somatic innervation? Somatic innervation means that the nerve supply is coming from the motor neurons, or not motor neurons, but the sensory neurons going to the somatic neurons going to the spinal cord. So basically, these are not autonomic nerves, these are spinal nerves, right? These were the the visceral innervation coming from the splanchnic nerves and stuff like that, but the innervation of the hindgut or the rectum below the pectinate line is coming from the somatic innervation. They contain the pain fibers, and that is why the external hemorrhoids are associated with severe pain if they get thrombosed. The blood supply is coming from the inferior rectal artery, which is a branch of the internal pudendal artery. The venous drainage is from the inferior rectal vein, that is a branch of the internal pudendal vein, and that drains into the internal iliac vein, common iliac vein, and ultimately inferior vena cava. The lymphatic drainage is to the superficial inguinal lymph node. The lymphatic drainage of the above the pectinate line was going to the internal iliac lymph nodes, while below the pectinate line they are going to superficial inguinal lymph nodes. You must remember the difference, that internal iliac and superficial inguinal. So below the pectinate line, the external hemorrhoids, anal fissures, and squamous cell carcinoma can be formed. Above the pectinate line, we had adenocarcinoma and internal hemorrhoids, and below the pectinate line, we are expecting the external hemorrhoids, anal fissures, and the squamous cell carcinoma. External hemorrhoids receive the somatic innervation by the inferior rectal branch of the pudendal nerve, and they are therefore painful if they get thrombosed. What is anal fissure? Tear in the anal mucosa below the pectinate line. There is pain while pooping, blood on the toilet paper, located posteriorly. Why? Because this area is poorly perfused. So, if the anal fissures are located posteriorly, that is a good sign, because it means that it is a benign kind of a condition, because the posterior wall of the rectum, that is poorly perfused, and that it has a greater chance of developing the tears or fissures and stuff like that if it is present on the anterior wall. So now we have to rule out the Crohn disease and some other malignancy, because normally the anterior wall is not the area to form fissures. If there are fissures in the anterior wall, so we have to rule out other conditions. It is associated with a low fiber diet and constipation. Then there is the Uworld point. The neonate fails to pass the meconium with anal dimple found instead of anal opening in the perineum. What is the diagnosis? The diagnosis is imperforate anus. The anal canal extends from the anorectal junction, that is perineal flexure, to the perineal skin, that is anal verge. So the anal canal extends from the anorectal junction Anorectal junction is the junction between the anal canal and the rectum. That is also called as the perineal flexure to the perineal skin, that is the anal verge. It is divided into upper and lower anal canal. The upper canal above the pectinate line is formed from the hindgut. It is a part of hindgut. The upper anal canal is a part of hindgut, while the lower part of the anal canal is derivative of the invagination of the surface ectoderm. The junction between these canals is closed during the embryonic life by an anal membrane that is located at the level of the pectinate line. Okay, the term imperforate anus covers the spectrum of, so basically this anal membrane, the remnant of the anal membrane in the adult human being, in the normal adult human being, is the pectinate line. But in the imperforate anus, the term imperforate anus covers a spectrum of disorders associated with the abnormal development of anorectal structures. The absence of the anal opening is most often associated with the urorectal, urovesical or urovaginal fistulas. So whenever there is imperforate anus, there may be an associated urorectal fistula, which means the fistula between the rectum and the urinary bladder. Urorectal. What is meant by that? Urorectal fistula. I guess it is with the urinary bladder, but that is urovaginal. Urorectal, urovesicular or urovaginal fistulas. I don't know about these things, like what is meant by urovesical or urovaginal fistula. I don't know. I have no idea, because I was expecting a rectovesical and rectovaginal fistulas, but they have written urovesicular and urovaginal fistula, and I have no idea what that means. But normally you must remember that the rectum, because there is imperforate rectum, so because of the imperforate rectum, the feces has to move in some direction. So it start moving either via the urethra, either via urinary bladder, or maybe through the vagina. So that is the concept of urorectal, the rectovesicular and the rectovaginal fistulas. I don't know about these urovesicular fistulas. We'll see that later on, inshallah. Where a fistula is present, meconium may be discharged from the urethra or maybe from the vagina. Then moving forward, the imperforate anus is most commonly associated with the genitourinary disorders like the renal degenesis, the hypospadias. The hypospadias is the condition in which the opening of the urinary bladder, suppose this is the penis, so in hypospadias, the opening of the urethra is located somewhat just below the penis, on the you may say that on the lower surface of the penis, on the ventral surface, right? So this is the concept of hypospadias. Then there is epispadias, in which the opening is present on the dorsal surface like this, and the bladder extrophy that may also be associated with the imperforate anus. Other congenital anomalies also occur in association with the imperforate anus, that is vectoral. Now you must remember the vectoral association and the concept of association. Associations are those embryologic abnormalities which tend to occur in a unison. They tend to occur together. There is no pathological association that why these things are happening together, but they are just found to be occurring together. That is why there is this kind of syndromic condition. This type of collection of disorders is called as an association. So the vectoral association is one of those associations which contain vertebral defects, the anal atresia, cardiac abnormalities, tracheoesophageal fistula, esophageal atresia, rectal anomalies, and limb abnormalities. The vectoral syndrome is much less common than the isolated urogenital abnormalities. Yes, like whenever there is urogenital abnormalities, they may be associated with any of these other conditions as well. The Uworld point is that lymphatic drainage of the rectum proximal to the anal dentate line occurs via inferior mesenteric and internal iliac lymph nodes. Areas distal to the dentate line drain primarily into the inguinal lymph nodes. Above that we have iliac lymph nodes, inferior or internal iliac basically, and distal to that we have the inguinal lymph nodes. Then we have the diagnosis, the treatment in RX, inferior rectal artery, internal pudendal artery. I don't know. Okay, I'm sorry. It is not treatment or diagnosis. It is a point coming from the USMLE RX that the inferior rectal artery gives rise to the internal pudendal artery, and that gives rise to the internal iliac artery. No, it is in reverse order. It is not like that. The internal iliac artery gives rise to the internal pudendal artery, and the internal pudendal artery will give rise to the inferior rectal artery, and the inferior rectal artery will supply the rectum below the pectinate line. Then we have this next part about the hemorrhoids. Above the pectinate line, superior rectal vein into the portal venous system. Okay, so above the pectinate line we have superior rectal vein that drains into the portal system, and below the pectinate line we have the inferior rectal vein that drains into the inferior vena cava. So there is an anastomosis, like a portosystemic shunt is being formed between the superior rectal vein and the inferior rectal vein above and below the pectinate line. So what are external hemorrhoids? Hemorrhoids are masses that typically protrude from the anus during the defecation. Hemorrhoids are commonly associated with constipation, extending constipation. Okay, whenever there is constipation, the people are straining and they may cause the protrusion of the hemorrhoids or even the formation of hemorrhoids. Whenever there is extended sitting and straining at the toilet, pregnancy, and the disorder that hinder the venous return. Number one, external hemorrhoids. External hemorrhoids are dilated tributaries of the inferior rectal vein below the pectinate line, and they are painful because the mucosa is supplied by the somatic afferent fibers of the inferior rectal nerves, and that is why the external hemorrhoids are painful, and they are located below the below the pectinate line. Suppose the pectinate line is over here, so they are not over there. Suppose the pectinate line, actually they are protruding downwards. So this is the dentate line, and these are the external hemorrhoids. These are internal hemorrhoids that are originating here and then moving downwards. So the external hemorrhoids are originating below the dentate line, and the internal hemorrhoids are originating above the dentate line. Now we have this thing, like over here, the hemorrhoids are protruding out of the anal opening. These are the internal hemorrhoids. Internal hemorrhoids are dilated tributaries of the superior rectal veins. What? Above the pectinate vein. Yep. So the external hemorrhoids are tributaries of inferior rectal vein, and the internal hemorrhoids are the tributaries of the superior rectal vein, and they are located above the pectinate line, and they are not painful because the mucosa is supplied by the visceral afferent fibers. Internal hemorrhoids frequently develop during the pregnancy because of the pressure of the superior rectal veins. The internal hemorrhoids frequently develop during the pregnancy because of the pressure on the superior rectal veins. Then here you can see that we have varices, internal hemorrhoids maybe. The anorectal arterial blood supply. So the arterial blood supply of the anorectus, we have the superior rectal artery. The superior rectal artery is coming from the inferior mesenteric artery. It is a branch of that. Then we have the superior rectal artery. The other two arteries are middle rectal artery and inferior rectal artery. Like this is the middle rectal artery and this is the inferior rectal artery, and both of these arteries are coming from the left internal iliac artery, and the left internal iliac artery will give rise to the left internal pudendal artery, and that will give rise to the inferior rectal artery, and the middle rectal artery is coming directly from the iliac artery and stuff like that. The venous drainage is like this. So here you can see the anorectal venous drainage. The superior rectal vein goes to the inferior mesenteric vein, and the inferior mesenteric vein goes all the way to the portal vein. The internal iliac vein is getting the blood from the middle rectal vein and the inferior rectal vein via internal pudendal vein and stuff like that. Moving forward, we have the liver tissue architecture. So the basic liver tissue architecture is the functional unit of the liver is made up of hexagonally arranged lobules surrounding the central vein and the portal triads. So that contain the central vein with the portal triads on the edges consisting of the portal vein, hepatic artery, and the bile ducts with as well as the lymphatics. So the functional unit is made up of hexagonally arranged lobules. So here you can see a you can't see over here. So there is no picture of that, but there are hexagonally arranged lobules. Like suppose if I draw it over here. So there are hexagonally arranged lobules like this. There is a central vein in the center, and at all the edges we have portal triads, like the circles which I am drawing right now. These are the areas of the portal triad, and inside the portal triad we have hepatic artery, the hepatic portal vein, and the bile duct as depicted over here. So the branches of hepatic artery, the branches of portal vein, and the bile ductule, they are present at the corner of the of this hexagonally arranged segment, and in the center we have this central vein like this. The central vein is present just in the center to the hepatic vein, and is timing circulation, but remember this point. Now the apical surface of the hepatocyte face the bile, the biliary canaliculi. The basolateral surface faces the sinusoids. Important point. Like the apical surfaces, they are facing the biliary canaliculi. As you can see, these are the biliary canaliculi like this. So the apical surfaces of the cell are facing the biliary canaliculi, while the basolateral surfaces are facing the sinusoids which are present over here. So these are the sinusoids. So you may remember like that even, that one of the surfaces of the hepatocyte, like suppose this is the hepatocyte, this thing, the apical surface is facing the bile, like one of the surfaces is facing the bile duct, and the other surface is facing the sinusoids, or the apical surface is facing the bile duct and the basolateral surface is facing the sinusoids. Okay. Then we have the Kupffer cells, which are specialized macrophages. Kupffer cells are the specialized macrophages and are located in the sinusoids depicted by the black arrow. Kupffer cells, Kupffer cells, where the black arrows, the black arrow is like where the Kupffer cells. Let me see. These are the Kupffer cells over here. So these are the Kupffer cells, and these are macrophages. You know that monocytes, we will see that in immunology, inshallah. But the monocytes are the precursor cells that are circulating in the that are moving in the circulation. When they get themselves housed into different organs, so they have different names. Like in the case of brain, we call them microglia. In the lungs, we have lung macrophages and stuff like that. In the liver, they are called as Kupffer cells. In the skin, they are called as Langerhans cells and stuff like that. So the Kupffer cells, they are specialized macrophages, are located in the sinusoids, and in the hepatic stellate cells, they are very important. They are present in the space of DISA. They store the vitamin A when quiescent and produce extracellular matrix when they are activated, and they are responsible for hepatic fibrosis. Now, what is space of DISA? The space of DISA is the perisinusoidal space. Like suppose this blue area is the sinusoid, this blue area is the sinusoid. Between the sinusoid and the hepatocytes, we have this yellow area, like this yellow area between them. That yellow area is the hepatic sinusoid, and this that yellow area is the space of DISA. As you know, they have shown the space of DISA over here. So the space of DISA contains these cells, which are the stellate cells, these pink cells like this one or maybe this one. So these cells are called as the stellate cells, and these stellate cells are responsible for storage of vitamin A when they are quiescent, and when they are getting activated. For example, at the time of regeneration or at the time of cirrhosis, they become activated and they go frenzy and they go crazy, and at that particular time they are responsible for the hepatic fibrosis. Now here you can see in the zone 1, there are 3 zones of the liver. The zone 1 is the periportal zone. So the periportal zone and the pericentral vein zone. Okay, so suppose let me redraw this. Suppose that we have a structure like this. The central vein is situated like this. So when the central vein is situated like that, the zone that is just adherent or just surrounding the central vein, that is called as zone 3. The zone that is closest to the portal system, like the portal systems are present over here as I depicted before. So the zone that is closest to the portal system, that is called as zone 1. Like the zone 1 is the outermost zone in a hepatic area. Like this area is a zone 1. This area is a zone 3. The venous area, the pericentral vein area, and between the zone 1 and zone 3 we have the zone 2, right? Okay, so this is the zone 2. These are anatomical divisions, and they are very highly significant, because there are some diseases which are specific for zone 3, and then there are other diseases which are specific for zone 1 and stuff like that. So now let's see them one by one. So the very first thing that you must remember is the zone 1, that is the periportal zone. It is affected by viral hepatitis. So the zone 1 is affected by the viral hepatitis. The periportal zone, the zone 1 is affected by the viral hepatitis, and ingested toxins, for example the cocaine, they are going to affect the zone 1 first. Why so? Because the viral hepatitis, if I am talking about hepatitis A, suppose, so the hepatitis A is going to spread via fecal oral route, right? So fecal oral route means that it is traveling via mouth and stuff like that. So the virus has entered the GIT, and from the GIT the virus will travel via portal circulation into the liver, because the portal circulation is a unique kind of circulation in the GIT, that it drains the blood from the GIT to the liver first before entering the inferior vena cava. So any kind of viral entity that is spread by the fecal oral route, or maybe the ingested toxins like the cocaine which are ingested, so they are definitely going to approach the zone 3 first. They are definitely going to approach the zone 1 first, right? The periportal zone. So when they are approaching the zone 1 first, so these areas wreak the greatest havoc in the zone 1. I'm talking about the fecal oral route, like the hepatitis A and hepatitis E, but same is also true for other viruses because of some reason. So the viral hepatitis and the ingested toxins like cocaine, they are going to affect the zone 1 more than any other zone. The zone 2 is the intermediate zone, and that is affected by the yellow fever. So zone 2 and yellow has also these two L's. So this means that the zone 2 or the intermediate zone is going to be affected by the yellow fever. Then the zone 3, the pericentral vein, the centilobular zone, It is affected first by ischemia. Why ischemia? Because we know that the portal triad, or the suppose this is the functional unit of the liver. What is that called? Let me see that. The functional unit of liver is made up of the hexagonally arranged lobules surrounded by the central vein. So suppose there is a hexagonal arranged lobule, and these are the portal triads. The portal triad contain hepatic artery. The hepatic artery is the only structure that contains maximally oxygenated blood coming to the liver, right? So if I am saying that there is a central vein and there is a zone 3, that is pericentral vein area, so it is at the highest distance from the hepatic artery, and that is the least oxygenated area as well. And if this is the least oxygenated area, so this is prone to develop ischemia at any whenever there is any inciting stress in the body. So you must remember this point. So now here you can see that the zone 3, the pericentral vein, centrilobular zone, affected first by the ischemia. High concentration of cytochrome P450 is present in the zone 3, most sensitive to the metabolic toxins, for example the ethanol, the CCl4, the halothane and the rifampin, and site of alcoholic hepatitis. The alcoholic hepatitis is happening in the zone 3. The viral hepatitis is happening in the zone 1. You must remember that. Then let's see this diagram. Here you can see that we have the sinusoids that drain the central vein. These are the sinusoids that drain the central vein. Then we have the endothelial cells which are lining the sinusoids. Then here the branch, the portal triad, which contain the branch of the hepatic artery, the branch of the portal vein and the bile ductule. Then we have the Kupffer cells which are present inside the sinusoids. Then in the space of Dissa, we have the lymphatic drainage as well as the stellate cells are present inside the space of Dissa, like this one. Then we have the next point, that is about the central vein to the hepatic vein and systemic circulation. So there is a central vein that is going to take the blood to the hepatic vein and then to the central circulation ultimately, and the bile flow. So direction of bile flow is opposite to that of the blood flow. Like the bile is flowing in this direction towards the bile ducts, and the blood flow is moving towards the central vein. Like the bile is flowing opposite to the central vein, away from the central vein, while the blood flow is moving toward the central vein. So you know they are moving in opposite directions. Now this is the picture. This is the PV. What is PV? The PV is the portal vein. This is the hepatic artery, and these are the bile ductile, like this one and this one. So they have tried to depict a portal triad with a portal vein, hepatic artery, and a bile duct like this. Then we have what is that? I don't know. I guess it is a hepatic sinusoid or something. Then we have the Kupffer cells in the liver, reticuloendothelial cells that remove the pathogens from the bloodstream. What is biliary structure? The gallstones that reach the confluence of the common bile duct and the pancreatic duct at the ampulla of Vater, the biliary structure or stricture. Okay, they are saying the structure. So the gallstones that reach the confluence of the common bile duct and the pancreatic duct at the ampulla of Vater can block both common bile and pancreatic duct, that is called the double duct sign, causing both the cholangitis and pancreatitis respectively. The tumor that arises in the head of pancreas. Okay, so basically let's talk about the basic anatomy. The basic anatomy is that this is the liver, right? And the liver is going to give rise to the common hepatic duct. The liver is going to give rise to the right hepatic duct coming from the right lobe of the liver, the left hepatic duct coming from the left lobe of the liver. Both of them fuse together to form the common hepatic duct. The common hepatic duct, okay, now let's talk about the gallbladder. The gallbladder will give rise to the cystic duct. The gallbladder is a storage area for the bile. The bile that is formed in the liver is stored in the gallbladder. Then whenever there is a need of that, due to the cholecystokinin mediated contraction of the gallbladder, the bile that is stored inside the gallbladder is pushed into the cystic duct. So when the cystic duct fuses with the common hepatic duct, that forms the common bile duct, right? So basically up till now we have seen the origination of the common hepatic duct from the liver and cystic duct from the gallbladder. Both of them fuse together to form the common bile duct. Then the common bile duct will fuse together with the main pancreatic duct to give rise to the ampulla of Vater. Not ampulla of Vater, to give rise to the hepatopancreatic duct that opens at the ampulla of Vater. The ampulla of Vater is basically an opening in the duodenum that is surrounded by the sphincter of ODI. Then there is a necessary pancreatic duct as well. The main pancreatic duct, the duodenum, is over here. The pancreas, these are structures of the pancreas: the head, the neck, the body, and the tail. Then we have the pancreatic duct is like that, endoscope and CHT. What is that? I don't know. So forget about that. Now let's move to the next point. So so about the tumors. Tumors that arise in the head of pancreas, usually ductal adenocarcinomas, they can, because the most common site of origin of the tumor, of the pancreatic tumor, is the head of pancreas. So whenever there is a tumor in the head of pancreas, you can see like head of pancreas is located over here, like this area. Whenever there is tumor in this area, it can obstruct the hepatopancreatic duct. So it can cause the obstruction to the common bile duct, and that will lead to the enlarged gallbladder and the painless jaundice, that is called the Courvoisier's sign. Courvoisier's sign means that when you palpate the right upper quadrant, you will feel the gallbladder, but that will not be tender. So that is called the Courvoisier's sign. We'll see that later on, inshallah. Cholangiography shows filling defect in the gallbladder. That is the cholangiography, or you may also call it a HIDA scan. It will show a filling defect in the gallbladder due to the blue arrows that show and cystic duct. Okay, so CHD, I don't know what is the meaning of CHD, chronic hepatic disease or something, I don't know. But if there is obstruction, like this was supposed to be a gallbladder like that, but our dye is not entering the gallbladder because there is some sort of obstruction either at the neck of the gallbladder or most probably at the neck of the gallbladder. So this is the problem over here. In the next picture, you can see about the gallstone ileus, a large, typically 2.5 centimeter, typically greater than 2.5 centimeter gallstone formation of a cholecystenteric fistula. So between the gallbladder and the adjoining gut, most often duodenum, due to the pressure necrosis and erosion of the distal tissues. So the problem is that cholecystenteric fistula means, cholecyst means gallbladder and enteric means a part of the GIT. So a fistula forms when the gallbladder is tethering with the duodenum. Most probably it's duodenum. So when it is attached to the duodenum, the gallstone from the gallbladder may enter the duodenum, and they may cause the obstruction in the duodenum like that. So a large, typically more than 2.5 centimeter gallstone causes the formation of cholecystenteric fistula between the gallbladder and the adjoining gut, most often the duodenum, due to pressure necrosis and erosion of these tissue. Fistula formation allows the passage of the gallstone into the small bowel, where it travels freely until it becomes trapped in the ileum and at the narrowest point of the intestine. The ileum is the narrowest portion of the intestine, and the narrowest portion of the ileum itself is the ileocecal junction. Patient consequently develop the symptoms and signs of bowel wall obstruction, including the abdominal pain, distension, nausea, vomiting, high-pitched tinkling bowel sounds, and tenderness to palpation. Abdominal X-ray may reveal the dilated loops of the bowel with air fluid levels due to the intestinal obstruction. Communication between the intestine and the gallbladder may also allow the gas to enter the biliary tree, that is called the pneumobilia. Normally, the air is not present in the biliary tree. If you are finding the air in the biliary tree, that is always an abnormal sign. You must suspect that some sort of cholecystenteric fistula has been formed, or the abnormality is going on at that particular point, or there is maybe ascension of the microbes into the biliary tree and stuff like that. Then we'll talk about the femoral region. It is very important because after that we are going towards hernias maybe. Yeah, they'll come soon. So the femoral region organization, like femoral region is the area just below the inguinal ligament. There's a triangle over there that is called the femoral triangle. The femoral triangle is formed by three areas. Superior margin is formed by the inguinal ligament, this white area. This is the inguinal ligament. Then we have the sartorius muscle like this, and the adductor. The sartorius muscle is making the lateral border, and the adductor longus muscle is forming the medial border of that. And then this is a triangle. So this is called the femoral triangle. Now let's come back. The organization from lateral to medial, from outside to inside, you can see there is a naval organization, that is nerve, artery, vein, and lymphatics. So here you can see that the femoral nerve, then we have femoral artery, the red one, the femoral vein, the blue one, and the lymphatics are present in this femoral ring side of the femoral hernia. So these things are coming from the lateral to medial direction. We have the naval organization, that is the naval organization means that we have nerve, artery, vein, and then lymphatics. So you go from the lateral to medial to find your navel. The femoral triangle contains the femoral nerve, artery, and vein. In the femoral triangle, we exclude the femoral ring. In the triangle, the only things that are present are the nerves, arteries, and veins. Venous near the penis. You may also remember it like that because if this is the vein and this is the vein and this is the penis over here, so the venous system or the veins are just close to the penis. Then femoral sheath, the facial tube that is 3 to 4 centimeter long below the inguinal ligament that contains the femoral vein, artery, nerve is not present in the femoral sheath. Remember, the sheath is enclosing only the vein and artery and the canal deep inguinal lymph node, but not the femoral nerve. What is the basic function of the sheath? The arteries and nerves in most of the regions of the body, like suppose this is the artery and then we have a vein. The arteries and veins are mostly enclosed together inside closed sheaths. The purpose of the formation of those sheaths is just give me a second. Okay, good. I lost the colors. I guess this one is good. So the purpose of encasing these things in a sheath is that the arteries are pulsatile systems. The arteries are high pressure systems, while the veins are low pressure systems. So due to the pulsations in the artery, the veins also get stimulated, and they also get squeezed, and the blood starts draining into the circulation. So they are enclosed in a sheath so that the arterial pressure could drive the movement of blood inside the venous system. So this is a basic concept through which you can remember that whenever we will talk about the femoral sheath, we are basically referring to the femoral artery and the femoral vein. They are not going to include the femoral nerve. The femoral sheath does not contain the femoral nerve. Remember that. So here they have shown like this outpouching like this. So that is containing the artery, the nerve, the vein, and the lymphatics, not the nerve. Then we have anterior abdominal wall layers. So the layers of anterior abdominal wall are, the first one is skin. Below the skin we have the superficial fascia, that is also called as the Kemper's or the Scarpa fascia. The Kemper fascia is the fatty portion of the subcutaneous tissue. The Scarpa fascia is the fibrous portion of the superficial fascia. Then we have external oblique muscle, the internal oblique muscle, and the transversus abdominis muscle. The organization of these muscles is very important because when we will be talking about hernias and stuff like that, so the arrangement of the muscle is very important. So firstly we have external oblique muscle, then comes the internal oblique, and then the transversus abdominis muscle. Then we have the transversalis fascia that is present below the transversus abdominis muscle. Then extraperitoneal connective tissue, and ultimately we have the parietal peritoneum. Superficial fascia. The superficial fascia of the anterior abdominal wall below the umbilicus consists of two layers. The first one is the Kemper fascia, that is the fatty area, and the Scarpa's fascia, which is the membranous or maybe the fibrous component of the subcutaneous or superficial fascia. The fascia is the Kemper fascia or the fatty fascia is the outer subcutaneous layer of the superficial fascia that is variable in thickness owing to the presence of the fat. The Scarpa or the membranous fascia is the deeper layer of the superficial fascia devoid of the fat. It is continuous into the perineum with various perineal fascial layers like the Cooley's fascia, the Darto's fascia of the scrotum, the superficial fascia of the clitoris or maybe the penis. Then, then the contribution of the external abdominal oblique muscle aponeurosis. We'll keep this session till here, and then we'll continue from these contributions in the next session. Until then, Allah Hafiz, fi manillah, and take care.